Greetings, everybody. You got me, your hands are up. I'll give you all I have. Well, that's good. Dr. Weil, how you doing? You can hear me, right? Greetings, everybody. You there, Dr. Weil? I'll give you all I have. Well, that's good. Dr. Weil, how you doing? You can hear me, right? Greetings, everybody. You there, Dr. Weil? I'll give you all I have. Well, that's good. Dr. Weil, how you doing? You can hear me, right? Greetings, everybody. You there, Dr. Weil? I'll give you all I have. Hi, Dr. Speer.
Hello.
How you doing?
Fine, thank you. How are you?
We got 4 minutes.
Sure.
Yeah, you showed up on the panel yesterday.
Yes.
Did you see that?
Yeah,
Yeah, it was great. No, he came from China.
true.
That was nice. I sent him an invitation. I was surprised he came.
It's a pleasure always.
And Dr. Borba, your buddy, has been doing
Yes.
great webinars from Brazil.
From Brazil. We were supposed to be there in Brazil for the skull-based conference, but it was cancelled because of
Oh,
Corona.
okay. Was it
So I
supposed
said
to,
that's why.
was it supposed to take place at this time?
Absolutely, yes.
Oh, okay. So I guess that's why they're having the webinar now. They have it all week.
Absolutely.
They have it
again,
today,
that-
matter of fact. Today
That goes to show that the webinar that you are doing is the thing for the future, because people will not be able to travel in the future like they used to do in the past.
well, you realize that, but I think Dr. Borba is realizing that too.
Yeah, sure.
He's seeing it now because he's getting a lot of people.
Sure.
And even though I'm not televising it, I'm putting it on the front page, and he's distributing it through our channel too. So it's an additional place where people can see his webinar. So So things the same with you? You operating at all, or just emergencies?
Just emergencies and clinic for patients, outpatient, with some restrictions on the number and how you deal with them, and with the mask and the gloves and so on.
Oh, okay. Okay, it's the same pretty well everywhere that I've spoken to. There are various parts of the world, they're opening up elective surgery a little bit. These countries are out of the way countries.
Yeah.
They haven't been hit by hard. Do you like the poster I made with the background of the Jordan?
Yeah, of course. Yeah, you can use so many backgrounds. I'll put
Well,
some today about the Dead Sea and so on, so you can use them anytime.
Yeah, there's certainly a wealth of images to use. So well, I just try to pick a good one.
Sure.
Okay, just less than 1 minute. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach. This is Dr. John Bennett from Neurosurgical TV. Today we have another episode of the Jordan Grand Rounds from Amman, Jordan, with Dr. Ibrahim Sabeya, who's been doing these multidisciplinary presentations for 27 years. So we'll turn it right over to Dr. Sabeya and let him take over. Welcome, Dr. Sabeya.
Thank you very much indeed. And again, for people who are joining us, my name is Ibrahim Sabeya, and I'm talking to you from Amman, Jordan. I'm talking to you from our clinic, which is something advancement on the confinement that we had for so much time. One can now go to the clinic and see some patients and do some emergency surgery. So I say good day to you, wherever you are, and we'll proceed. The topic for today would be about the radical excision of a craniopharyngioma. And as the title give you an impression that I am with the radical excision of a craniopharyngioma, and I'll explain why. So this is sort of conclusion of my lecture, that radical excision is the best thing for the patient, and we will go through that in details. Some pictures of Jordan before we start. You all know that the Dead Sea is in Jordan, and here's a picture of Jordan. We are on the Mediterranean here, and we have the Dead Sea. Jordan is overlooking the Dead Sea and overlooking the Red Sea. So we have two seas to go to. And the important one to talk about is the Dead Sea. So here you are, this is the aerial view of the Dead Sea. This is north, this is south. And you can see that it is salty, and that's why it is called Dead Sea, because of high concentration of salts in it. So there is no marine life whatsoever, no fish, nothing. And here you are at the lowest point on Earth, 420 meters. And it is getting more deeper every year, because there is evaporation of the water of the Dead Sea because of lack of water coming to it from the River Jordan. But just at this time, it is 420 meters below sea level. And you can move from this lowest point on Earth to the heights of Amman at heights of 1,500 meters, where you can have snow. So this is some of the pictures of the Dead Sea for you to enjoy.
Yeah, I don't think you're sharing them, Doc. I'm sorry about that. I got distracted. I'm sorry, audience.
So start again?
Yeah, please. Yeah, that would be great. I'm sorry. I missed the lack of screen sharing.
No,
So
no problem.
Okay, let's start again. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett broadcasting from Miami. We have another in the episode of the Jordan Neurosurgical Grand Rounds. And I'd like to welcome Dr. Subbiah. He's been doing this for 27 years, and now he's taking to the internet, I'm glad to see. So welcome, Dr. Subbiah. It's all yours.
Thank you very much indeed. For those people joining us for the first time, my name is Ibrahim Subbiah. I'm professor of neurosurgery here in Amman, Jordan, and we are transmitting live from the Farah Medical Campus here in Amman. Good day to you wherever you are. The topic of the lecture is radical accession of the craniopharyngioma, and it speaks for itself. I am an advocate for radical accession of craniopharyngioma. Some pictures from Jordan before we start. This time we choose to speak to you about the Dead Sea of Jordan. This is the map of Jordan, and we have two seas in Jordan, the Dead Sea and the Red Sea. And this is an aerial view of the Dead Sea, and you can see the white color because of the high content of the salinity and salts. That's why there's no marine life in this Dead Sea, and that's why I call it Dead Sea. And here you will be at the lowest point on Earth. There's no lowest point on Earth except this one. This is the lowest. 420 meters, and increases every year because of the lack of water coming to the Dead Sea by the River Jordan. So it's 400 meters and increasing every year. The astonishing thing that you are here at the sunshine of the Dead Sea at this lowest point on Earth, and within half an hour you can be at the heights of Amman at 1,500, 1,700, where we have snow every year. So these are some of the pictures to share with you about the Dead Sea. Beautiful sceneries and beautiful formation by the salt. This is at sunset. Beautiful view. So many hotels and lucrative facilities there on the Dead Sea. Imagine yourself at that spot at this time of the year where it's really very, very good weather. And of course, the important thing about the Dead Sea that you can not get drowned because the water will take you up whatever you do, except you're absolute fool, then you can get drowned. But if you just throw yourself and leave yourself, water will take you up, you can read your newspaper. And the famous mud bath, famous in Jordan for so many diseases. So we'll talk about the radical accession of the craniopharyngioma, and I'm giving you my personal series on this topic. First of all, let's speak about the origin of craniopharyngioma. We all know that we have two processes, one starting from the brain, from the infundibulum going down, and one starting from the mouth, from stomaderm going up. So that's why it's called the craniopharyngioma. So the two processes meet. This is going to do the posterior pituitary. This is going to do the anterior pituitary. So this happens during 4 weeks of gestation. Gradually, they just fuse together, and this process, which went up from here to there, will disappear. Sometimes it persists. Sometimes it persists as a cleft. Sometimes it persists as a cyst. And sometimes it persists as a tumor, which is the craniopharyngioma. So the craniopharyngiomas, the commonest type is in the middle. 80–85% are cellular supracellular. Only 5 to 10% are only cellular, and only 5% are going solely in the third ventricle. So we speak about totally third ventricular lesion with no connection whatsoever to the cellular area. So 5%, 5 to 10%, and the commonest is these cellular supracellular tumors. Sometimes you'll find, that's why because of this embryology, you will find the intrachiasmatic craniopharyngioma inside the chiasm itself. This paper from Spain showing this. And this beautiful paper I have to refer to you, I have to point out to you, is from Steno from Slovak Republic, where he tried to find the relationship between the tumor and the floor of the third ventricle. So he called it third ventricle relation with the craniopharyngiomas. And he found this, that either you are extraventricular, so the tumor is still outside the ventricle. This is the floor of the third ventricle. So, or the tumor is outside the ventricle, it is extraventricular. Or the tumor is totally intraventricular, or the tumor is both intra and extraventricular. This is a very beautiful paper for young neurosurgeons to read. And Dr. Pascal from Argentina, this paper, beautiful paper, he pointed out that with the enlargement of the craniopharyngioma, the mammillary bodies will actually shift to the side. So it will go to the side like this, up like this, up like this, up like this. So here you are, the anatomical cadaveric features and the radiological features. That's an important paper because this is the clue that you can do radical excision of a craniopharyngioma without affecting the hypothalamus. That is the main reason why most of the neurosurgeons or young neurosurgeons do not want to go for surgery. They would go for biopsy or just radiosurgery because they don't know this fact, which is very important fact. So here we are, the radiological and the cadaveric, where these mammillary bodies are, which is the hypothalamus. So here we are with the size, increase the size, the mammillary bodies which are here will go to the side. So the floor of the third ventricle is open for you, it's opened by the tumor. And if you take the tumor from there, you will not damage the hypothalamic nuclei. So that will take us by default to the anatomy of the third ventricle. So you will deal with the third ventricle, so I have to know the anatomy by heart. So this is the third ventricle. It's an anterior wall, it's a roof, posterior wall, floor, and of course lateral walls. This is a 3D of where the third ventricle is in relation to the sella and to the other ventricles. So here we are, third ventricle, anterior wall, superior wall, posterior wall, floor, and 2 lateral walls. And of course, this is the thalamus, this is the hypothalamus, this is the sulcus here between the thalamus and the hypothalamus. So this is the hypothalamus. Let me take you through that. This way, and so on. Now, if you put the brain on it, you can see the crus cerebri in addition. So let's look at that in some details. Look at the anterior wall, look at the roof, the posterior wall, the floor, and the lateral walls. The anterior wall is this. It's made by the lamina terminalis, which is just a glial tissue extending from the top of the chiasm till the anterior commissure. The roof is made by the body of the fornix, and underneath it is the tilla choroidea with the 2 internal cerebral veins. The posterior wall is made by the internal cerebral vein joining together with vein of Rosenthal to form the vein of Galen, of course the pineal gland with the suprapineal recess, the posterior commissure. Of course here we have the ependylar commissure. The floor, as you can see, is made of these 2 mammillary bodies, and in front of them is this sort of area that you can actually penetrate to do the third ventriculostomy, and then the tuber cinerum giving rise to the stalk. So mammillary bodies and the tuber cinerum and the stalk go into the pituitary gland. If you look at the floor from above, this is anterior, this is posterior, so this is the chiasm, and then you'll get the chiasmatic recess, and then this is the floor, the tuber cinerum, mammillary bodies, and this is the floor of the third ventricle, which is overlying the midbrain. And this is, as you said, is used for doing the third ventriculostomy. The lateral wall is the most important because it contains all the hypothalamic nuclei. And the creator made these nuclei in groups. We have anterior, middle, and posterior group. We have the paramedian, middle, and the lateral group. So this is the third ventricle, and we have 3 groups here, middle, and outside lateral. So medial, intermediate, and lateral. Again, this is the picture, the anterior group, the middle group, and the posterior group, which are arranged in this important fashion. And each nucleus is responsible for certain function. So we have three groups of nuclei in the sagittal plane. Again, this is the 3D. You can see the nuclei. This is the third ventricle and the group of nuclei arranged. Hypothalamus is only 4 grams in weight, but it is the 4 grams that control your very essence. It controls the pituitary, the sympathetic, the parasympathetic, food intake, fluid intake, metabolism, growth, sex, reproduction, temperature control, circulation control, sleep wake-up cycle, attack and defense, memory. So it's very important anatomy of the hypothalamus. If you have a lesion in that area, cellular, supracellular area, what is the differential diagnosis? In addition to craniopharyngiomas, adenomas, of course, Rathke's cleft cysts, meningiomas, supracellular meningiomas, epidermoids, and all these cases I'm showing are my cases. This is one case of mine with hypothalamic hamartoma that you can misdiagnose as a craniopharyngioma. This is before surgery, after surgery. Germinomas, they can look like craniopharyngiomas, histiocytic sarcoma. All these cases are mine. Immature teratoma, this Bahraini girl who came to me, histiocytosis of glioma, astrocytoma of the hypothalamus, lymphoma, chordoma extending into the supracellular area, plasmacytoma, sinonasal carcinoma, metastasis, sarcoidosis, aneurysm, and so on. If I may ask you to stop at this and look, well, how the differential diagnosis, only in this kit is small group of pathology, but this will take us to the question of how people would dare to give radiation without histological diagnosis. Imagine giving radiation for sarcoidosis or for even plasmacytoma. Osteoma, choroid plexus papilloma, oligodendroglioma, arachnoid cyst, neuroblastoma, all are in the differential diagnosis. So again, that is a point to be taken against people who radiate patients without histological diagnosis. So what is the management of these craniopharyngiomas? First of all, you need a dedicated team. It's not only the neurosurgeon. You have to have a good anesthetist, a good neurologist, endocrinologist, ophthalmologist, neuroradiologist, neurophysiologist, radiation oncologist. And I have made my partnership with these people over the years. We are sort of a team who knows each other well. We've been together for 25, 30, 35 years, working together. So we know each other in and out, and we know exactly what to do. It's a teamwork. It's not one-man show. So the treatment modalities that we are offering our patients are surgery, which is the mainstay, and I repeat, the mainstay. There is a radionuclide in the form of chemotherapy, and then radiotherapy, whether it is conventional or stereotactic. As for surgery, so many approaches for the lesions: transcortical, transventricular, transpilosal, transventricular to go to the lateral ventricle through foramen of Monro to the lesion. We can use the subfrontal, frontotemporal, transbasal, which I like, transpetrosal, and then you can go through the nose either by microsurgeon, by microscope, or by endoscope. So basically, let's put the conclusion from the very beginning. Surgery is either for a partial resection with the mind of the surgeon thinking, well, I will do a small decompression and then send for radiotherapy, or the surgeon going in with the state of mind, I want to do radical resection. I am of this group, I subscribe to this group, I do not advocate this group whatsoever, and I will show why. And it is clear here, if you do radical excision, you have less recurrences, less procedures, and no radiotherapy complications. So I repeat, and I've been saying this for so many years, it is your state of mind as a neurosurgeon when you start the operation. Am I going to go for biopsy or am I going for radical excision? Because this is what we are going to do. If you planned ahead that you are going for biopsy, you will only do biopsy. You should go for radical excision. And only if you just can't, if it is impossible to remove, then you will go for partial excision and then radiotherapy. So, radical approach. People say there is no border of cleavage. My experience is that there is a frequently a gliotic border that we can identify. Most of the major neurosurgeons in the world who are doing this surgery, they will tell you this. There is a gliotic border, but you are not looking for it. You have decided, you have resigned yourself that you are going to take a biopsy. And I believe in this very much indeed. Neurosurgeon experience has an impact on extent of resection. Good neurosurgeons, experienced surgeon, most of the time, they will go for radical surgeons. Mediocre surgeons, without experience, they will go for biopsy. And I will show you the large names in the neurosurgery who've been doing this. From Lowe's, from Falbush, Caldwell, Frank and John Jane Sr. and Jr., and Yezergil, Professor Simon Hoffman, from a long time ago as a pediatric neurosurgeon in Toronto, Canada, has been doing radical excision of these cases. I don't have to convince you, you just have to go and see these names, DiRocco, for example, and so on. So go and see that these giants of neurosurgery have been doing radical excision and not simple biopsy. So these are the major surgical series which I mentioned for anybody to read and look at them. I've been doing my homework a long time ago and I'm just presenting this to you. Let's see this. Harold Hoffman from Toronto, a major pediatric neurosurgeon, one of the founders of pediatric neurosurgery. Back in 1977, Journal of Neurosurgery, Management of Craniopharyngiomas in Children. He would go for radical excision, as you can see. Professor Yezergil. Professor Yezergil has been in Jordan many times. He's a friend of Jordanians, friend of our society. This paper, back in 1990, 144 patients, radical excision. This is the man of century of neurosurgery telling you this. Again, back in the 1994, in humans and in so on, Carmel said, we advocate radical resection as the optional treatment in all patients, if possible. If possible means that if there is no way that you can remove it completely, then you can go for partial or subpartial, subtotal excision. And look at this statement, important. Incomplete resection is a virtual guarantee of recurrence within 3 years. It's a guarantee. If you do some biopsy, partial resection, then you would end with the major recurrence in small time. And then what are you going to do with this recurrence? Another surgery, you will damage the hypothalamus. A radiosurgery, you will damage the hypothalamus. From Argentina, radical resection of craniopharyngioma, 2005. You will say, oh, we'll just decompress. Nonsense. Radical excision. Craniopharyngiomas in children, surgical experience at Children's Memorial Hospital. And this is back in USA 2005. Total resection provided the best outcome. So it's not me. I'm not only advocating this. It's these people, these tutors, these major giants of neurosurgery who are doing this. Radical excision of a craniopharyngioma is the best approach. Osama al-Mufti, as you know, is a Syrian residing in the United States, a major skull-based surgeon, close friend of my family and myself. Back in 2007, published this paper about betrothal approach for total removal of giant retrochiasmatic craniopharyngioma. You would say, oh, this is impossible to remove. It is possible to remove, but you do not want to go into the surgical expertise of doing this. You would just go for biopsy and send patient for radiotherapy, which to my mind is a crime. From Christian Saint-Rose in France, he's a major pediatric neurosurgeon, Hospital in France, Malade in Paris, 2007. The best overall results is achieved with complete resection by experienced craniopharyngioma surgeon, not for mediocres, not for those people who not know how to do neurosurgery. Falbush, one of the giants of pituitary and craniopharyngioma. Here we are together with Professor Sami in Bulgaria, and here he's visiting us in Amman. Falbush advocates aggressive removal. He published his paper in ACTA 2008. Complete craniopharyngioma resection with acceptable morbidity can be obtained in 80 to 90% of cases. From China, 2008, radical resection of 202 pediatric craniopharyngioma. Radical resection. No radiotherapy. Paper from China, craniopharyngioma, surgical experience of 309 cases. Look at their conclusion. Total tumor resection is feasible with the preservation of vital structures with lower recurrence rate and low morbidity. What more evidence do you need? This is one of their papers showing the pituitary, the carotid, third nerve, and the tumor coming this way through cerebral approach. Then comes this paper from Korea, 2015, with a question: is the complete resection of craniopharyngioma in adults is feasible? The answer is yes, yes, yes. Professor Sami, his paper from Hanover, 65 cases of mostly giants, and he could achieve cross-total resection in 64 out of 65 cases. Professor Ed Lowe's from Harvard, again, a friend of Jordan, a friend of my family. Here we are with our wives, wife of Professor Lowe's and my wife, and here he is visiting us in Jordan. And what would he say? Look at this. Unfortunately, non-surgical options have provided limited benefits while incurring their own risks. Non-surgical options should be reserved as adjuvant following surgical management. These are quotes from a giant of pituitary and craniopharyngioma surgery. The best long-term outcomes have been reported following gross total resection. You need more evidence. I'll give you this from my clinic, 2018. Pediatric craniopharyngioma, premiere for the skull-based surgeon. Giant or no giant? Radical excision. Radical resection of craniopharyngioma from Japan, 2018. Published in the Asian Journal of Neurosurgery. Oh, this is complete, a large craniopharyngioma. Let's just go for puncturing of the cyst or whatever. 81 patients, radical excision from Japan. My clinic, Rochester, 2018, and this is the paper. Maximal safe resection via microsurgery or endoscopy provides very good tumor control. So, radical excision from Japan, 2005. Not only for the virgin first-time surgery, but even for the recurrences. Even if you have recurrence, the first choice in the recurrence is surgery and not radiation. And this paper from Japan is proving this. These are recurrent cases, and this is the surgery done for them. Another paper using the surgery for the recurrences by Wizard from the United States, 2007. Journal of Neurosurgery Pediatrics, efficacy and safety of radical excision of primary and recurrent craniopharyngiomas in 86 children. Radical excision of recurrences. Are there any complications? Of course there are. And these complications can be centered on the pituitary, on the hypothalamus, on the optic apparatus, on the brainstem, on the temporal lobes. So we speak about general neurosurgical complications, recurrence, and mortality. Of course there are. Of the pituitary, usually with almost all of the cases, you'll have some hormonal disturbances in about at least 25% of cases, which post-treatment would increase. No case would come with the normal hormonal function after surgery. All of them will have some abnormality. So they would require thyroxine, they would require growth hormone, they would require diabetes insipidus treatment. Hypothalamic complications. You may get hyperphagia, which leads to obesity. You may get sleep disturbances, temperature disturbances, and psychological disturbances. Obesity. Pre-treatment, you see it in 35% of cases. And if you see it, it will not change. But those cases who did not have obesity pre-treatment, most of the time they would lose it after the surgery. Visual pre-treatment, 50 to 80% of patients. Some of them recover, some of them don't. General neurosurgical complication, hydrocephalus, vascular injury, cranial nerves, seizures is part of the game. What is the prognosis? And this is from Finland Cancer Registry, USA National Database, German Channel Registry. Look at this. 5-year survival overall is of 73%. From USA, 80% overall 5-year survival. From Germany, 98% 5-year overall survival. So surgery is the mainstay, and it will give you a very good prognosis. Again, this is from cases to show you that there is sometimes ectopic recurrence. So you would find that there is recurrence of the tumor somewhere far from the site of the tumor. Here is cortical seeding of a craniopharyngioma, away from the site of surgery, cortical. Then we come to the use of Ommaya reservoir, which I would allude to later on. And I will just start with this from Mayo Clinic, 2018. Ommaya reservoir is a palliative should be left for, sorry, it is not well written, it is left for resistant cases and should never be as a first-line treatment. Ommaya reservoir should never be considered as a first-line treatment like most of the neurosurgeons do. Of course, one of the complications is recurrence, and recurrence could be in the same site or other sites. And this paper is an ectopic recurrence in the temporal area from China. And these are the list of the publications about the ectopic recurrent craniopharyngiomas. So it could be anywhere: frontal lobe, spine, interhemispheric, posterior fossa, anywhere. Ectopic recurrence, you can see it here in the frontal area from Korea. Ectopic recurrence from Alicrest, from Little Rock, Arkansas, in the posterior fossa. From Germany, seedling of craniopharyngioma, like this. Ectopic recurrence of craniopharyngioma along the surgical route, so you can see it this way. This was a transcallosal approach from Finland, from Juha Haadesemini, the famous vascular surgeon. Ectopic recurrence of a craniopharyngioma in 15-year-old girl 9 years after surgery and conventional radiotherapy from Sweden. And a rare case of ectopic recurrence 17 years after initial presentation. So they can recur in various bizarre sites. Here, recurrence in the subgaleal area from Brazil. From China, again here is ectopic recurrence. From USA, recurrence in the temporal area. The recurrence and the impact of the tumor topography here is important. Measuring this angle to see how wide and how far the non-memory bodies would move. Again, this is from Jose Maria Pascal, a very important landmark paper. With the Steno papers and Pascal papers, you can understand that you can achieve radical accession of craniopharyngiomas. From India, this recurrence along the sides, and from China, this posterior fossa recurrence. And the same thing, recurrence. So all these cases showing unusual signs of recurrence of these tumors. I will point out bad practices, and I have strong feelings and strong views about this. If you find me that I'm really agitated, it's because I see lots of crimes. I'm not the best surgeon in the world. I am a surgeon who's trying to be a good neurosurgeon, but I see lots of bad practices. And one of them is insertion of Ommaya reservoir as upfront as a primary treatment. You know why? Because that surgeon doesn't know the anatomy of the third ventricle, doesn't know the embryology of the craniopharyngioma. He's a mediocre. He is not a good neurosurgeon. What about Umayya? I have great respect for this man. He's of Pakistani origin, and Ayub Umayya is from Pakistan, who actually went to study in Oxford in England and then immigrated to United States. And there he started his work on what he found or what he invented as Umayya reservoir back in 1965. Look at this. He made his work and thesis about how to introduce certain antibiotics and pain management for cancer to the ventricles through something which he invented and called Umayya reservoir. So this man did not intend to treat the craniopharyngiomas. He wanted to put something inside the ventricles. But the majority of neurosurgeons now is using this for no good reason, for no good scientific reason. They cannot defend even why they are doing this. So this is Umayya reservoir. What are you doing here? Putting Umayya reservoir for this shunt? Go ahead and take it out. And instead of putting Umayya and then obstruction of the Umayya, revision of Umayya, this, that, and the other. Another bad practice, which I'm very much against, is this shunt. This is, I said, this disease in the Arab world. It is a disease of this part of the world. Putting a shunt for everything. A good shunt is no shunt. You would not like to put a shunt in the brains of your sons and daughters. Why do you put it in the brains of others? Simply because you cannot do the surgery. And they claim, oh, we had to do the shunt because it was an emergency. Okay, if it's an emergency, put an external drain and refer your patient for an experienced neurosurgeon to do the final surgery. But do not do these crimes. Not only it is a crime, but look at these transverse shunts. So these people are trained. We in this part of the world, and we have to admit this, we are training our residents to do shunts for everything. And once they do that, they think they are neurosurgeons. Because what they say, oh, I have done 300 cases during my career, but most of them are shunts. The worst crime ever is bilateral shunt. I have seen it. I have seen it. The tumor is obstructing both foramina of Monroe, so they go and put bilateral shunt. For goodness sake, do not do this criminology. That's why I published this paper back in 2009, the surgical neurology. I alluded to this last time, and I called it, do we need a neurosurgical Interpol because of these crimes? We do need a neurosurgical Interpol. Do we need? Yes. Should we consider the creation of a neurosurgical Interpol to exchange information about the few misbehaving neurosurgeons? We do. And we have to call the Interpol once we see a crime, neurosurgical crime, and this is going to be a war against a neurosurgical terror. It's a fight which can be won only if all the neurosurgical societies around the world joined in the neurosurgical Interpol to stop these malpractices which go unnoticed and unaccounted for. What about endoscopy? It's a very important tool in craniopharyngioma. As I always mention, endoscopy is the future, holds the future of neurosurgery. Endoscopy is a big tool, an important tool. And here one of the views going through the nose, this is the planum, this is the pituitary gland. And then when you do the endoscopic removal of the bone here and the dura, from opening, you will come across the optic chiasm, the right optic nerve, left optic nerve, and the tumor. And then you can control it. You can see the chiasm, the nerve on the side, and the nerve on the side, stroke, and all these blood vessels, which you can preserve. Beautiful endoscopy views, beautiful new anatomy is very important. But as the endoscopist will be able to see the blood supply from below, the microsurgeons will be able to see the blood supply coming from above as well. Here is the cavity of the third ventricle. Once you go to the lamina terminalis above the ACOM, you will find the cavity of the third ventricle as such. And this paper, 2000, these people, Enrico De Vitis and Paolo Capabianca from Napoli, Italy, are one of the giants of endoscopic surgery, and I'm glad to say that both of them are friends of Jordan. So these are the views they show: A1, A2, A1, A2, ACOM, the optic nerve, and the tumor, and after the tumor removal. It's a very good way of doing things. Amin Kassam and his group published this paper in 2008 in new classification of the craniopharyngioma in relationship to the diaphragm. So different kinds of craniopharyngiomas and how they extend and what should you do for each type of these classifications. Snyderman and Gardner, again back in Pittsburgh, published this paper 2013, radical excision of craniopharyngioma. Be it endoscopy or microscopy, everybody should go for radical excision. Do not go for what you call debulk or fenestration or decompression. This is all just in your minds. It is not in the books. It is not in the scientific teaching. It is not in literature. So stop doing it. From Italy by Giorgio Frank, again, a great neurosurgeon from Italy and endoscopist. You can go with the endoscope, various parts. These are both foramina of Monroe as seen from below after a section of the craniopharyngioma. Again, Frank Gentili, my friend from Toronto in Canada. We are close friends and I'm proud of this friendship. He published this paper about the total radical excision of this tumor. By the way, Fred Gentili is a microneurosurgeon and is endoscopist too. What about chemotherapy? The use of intracystic radionuclide. Nucleotides, since a long time ago, has been used, the bleomycin, yttrium. In my days when I was in the medical school, yttrium was mentioned as the treatment of craniopharyngioma, but that was some time ago. So like Umayya Reservoir, this is 65 years ago, so why should we go back to the old practices? Let's see, use of interferon in the chemotherapy for cystic craniopharyngioma. Here's the tumor and here's 2 years later. You have kept the damage here on the hypothalamus and on this patient. Why did you go for radical excision? Same thing here, but this is worse. This is the tumor, and this is intracystic chemotherapy with the bleomycin, and this is 2 months later, flaring above things, because these materials of chemotherapy has their own complications. This paper published in Child Nervous System from China using Umayya Reservoir to treat these cases. Look at this. I mean, what is this result? Can anybody tell me what is this result? And remember that you have to do the intracavitary irradiation once, twice, 3, 4 times. And if any of these intracavitary radiations or chemotherapy slipped outside the track, then you and the patient are in trouble. So, radionuclide should not be given for any patient expected to go for surgical excision. And look at this beautiful paper published 2012 by Winklew. And what he says is this: searching multiple databases, look at this, databases, articles, reviews, conference proceedings, trial databases. He looked at all this. We were unable to promote treatment with intracystic bleomycin in children with craniopharyngioma. I think this should close the chapter of these materials used in the treatment of craniopharyngioma, except in the dire stated, except in the cases that we've lost the battle with. What about radiotherapy? Again, this is a field of malpractice. Whatever the radiotherapy is, external beam or conformal or intensity modulation, proton beam or stereotactic or brachytherapy, it's just the same. It should not be as used as the upfront primary treatment. Why? Because they have high morbidity. And the high morbidity are, as you all know, long time ago, for so many decades, cognitive function, visual changes, panhypopituitarism, vasculopathy, new neoplasm, which I alluded last time, of new tumors coming after gamma knife. We are seeing this more frequently because there is enough time that has lapsed since the giving the treatment of gamma knife. So this is one case of mine who was giving radiotherapy, and you can see the brainstem necrosis, the temporal lobe necrosis. What about using the high-tech from Harvard 2006, combined proton and photon irradiation? Advances in the management of craniopharyngioma using stereotactic radiotherapy and three-dimensional conformal proton radiotherapy. And look at this paper comparing conformal proton with other types of radiation. Is there any difference? The answer is no difference. These are their data. Recurrent craniopharyngioma after conformal radiation and the burden of the treatment. This is the patient before, and this is the complications. This is from Frederick Poop in Memphis, Tennessee. This paper, they have treated, this is the same paper here. Details, they treated between 98 to 2010, 97 patients, and their conclusion, craniopharyngioma progression after prior irradiation is exceedingly difficult to treat, and local control is challenging despite repeated surgical procedures. So they're telling you, don't do radiation. Given our results, gross total resection may need to be the surgical goal at the time of first recurrence. You have recurrence, your first goal is surgery and not radiation. And these are the details of their cases. So radiosurgery, it has its limitation. The size should be small, it should be away from the optic apparatus. This completely defies anybody using radiosurgery for craniopharyngioma. It is by default a lesion which is in touch and in contact with the optic apparatus. They would come with certain tricks. They would say, oh, they will block the pathways going to the optic pathways. This is not on. You cannot convince me, you cannot convince anybody with good brains that giving radiosurgery upfront to the craniopharyngioma is the first choice. It is not the second, it is not the third, not even the 100th choice. Surgery after gamma knife is difficult, as I alluded to many times, and of course the malignancy, which we are just seeing the tip of the iceberg. And I'm speaking from the point of authority, from the point of experience. This is me 25 years ago, 25 years younger and more cute, bringing the first gamma knife to Jordan back in '96, and the very first patient that I treated. And I believe very long ago that gamma knife is a good tool, but it has to be in the good hands. This paper from Konziolka in Pittsburgh, 2001, showing you the effect of gamma. Fine, it's 1 year later. So what have we achieved? I have no idea. They speak about tumor control. We don't know about this, what's going to do, what is the natural history of this, how it's going to evolve, when it's going to recur, and whether it will come back with malignancy. Look at this paper from Japan, 2005, about long-term use of gamma knife for treatment of craniopharyngiomas. This is before, and this is 30 months later. The tumor is still there. What about histology? Usually our histology is done by my friend Dr. Hussam Farshak, who is American boarded. Most of the cases are done by him, and he will give you this beautiful pictures of the gross specimens that we remove. Don't tell me that leaving this in the heads of patients is of any justice for these patients. This is the tumor and not the cystic material inside. This is what should be removed and not the fluid. Two types of histology, the papillary type, the adamantinoma type. This is more in children, this is more in adults. This is the minority, this is the majority. In adults, the papillary, children, the adamantinoma, mostly solid. Here is mixed. Less adhesions here, more adhesions, no calcification. You may find calcification. So the worst type is the adamantinoma type, and unfortunately it is in the pediatric group of patients. We do all sorts of histology slides, and we do lots of immune staining. Dr. Farshak will give you all these results. cyto 19, EMA, epithelial membrane antigen, GFAP, low molecular weight cyto, high molecular weight and low molecular weight cyto, P63 and P53, and the Ki67 MPA. We published together with Dr. Professor many papers. One of them is this differential expression of immunohistochemistry markers for epithelial squamous type of adenocarcinoma. This was published in the International Clinical Pathology Journal. And this also has been also published. Is there any malignant tumors in craniopharyngioma? Yes, either de novo from the very beginning or on top of pre-existing benign craniopharyngioma. And in literature, we could identify 23 cases. This is one of them from UK, London. And this paper, malignant craniopharyngioma from USA. I'll speak to you about my personal series of craniopharyngioma. An average neurosurgeon might operate on one craniopharyngioma over 2 to 3 years. It is rare tumor. So in a person like myself, I've been a neurosurgeon since 1985, you'd expect that I would have 20 or 30 cases. But luckily for me, I had more than that because of the referral to Jordan from the surrounding countries. So my personal series, and I stop usually about 1 or 2 years before including the cases in the series, have 102, adults in 43, children in 59. The horrifying thing about these cases, the giant ones, more than 4 centimeters, constitute the majority. People don't want to operate on these cases, so they refer them to us for gamma knife. Of course, we refuse to give gamma knife and we treat with surgery. This is the cut down of these cases. The solid ones, 38, the mixed 58, and the, as I said, the large size is the majority. And these are my cases. These are the cases that I treated, usually large, giant, of very high proportions. Showed you in the sagittal, now in the coronal. You can appreciate that they are really giant. Now in the axial cuts, again, you can appreciate that they are real giants. So, 102 cases over this period of time. For all cases, we do history, physical examination, image visual assessment, endocrinological assessment, and I must emphasize this point, psychological assessment. You are going to the hypothalamus, and you have to have good psychological assessment before and after surgery. Endocrinology, you have to do all the hormonal assessment, the urine osmolality, the serum osmolality, the CT scan to see any calcifications. These are all my cases. The MRA, the MRV, and the angiography if need be. And we do the full visual assessment, visual fields, and we love to use the German assessment, which combines visual acuity with the visual field defect to give you a common score. Of course, we do the optic OCT, see with any atrophy of the optic fibers. And we do the evoked potential responses. We do the psychoanalysis, full psychological assessment by our experienced Dr. Ritzelhan, psychologist, psychiatric specialist, with his assistants, including Karnofsky performance scale. I'll just go through now a few of a list of cases, and then we'll be finished by showing you a few videos. I use many approaches, the conventional pterional approaches or the interhemispheric approach. I'm not trying to use any approach that suits the patient. I'm not a prisoner of one approach, so I use the case as I see it on images and I see the size of the tumor. But with this the terminal approach. Sometimes, as I said, you have the blind angle here at the middle aspect of this nerve and the chiasm. Interhemispheric approach will give you the dexterity to go right, left, and center. Here, the tumor is presenting in the lamina terminalis area. Opening it will take the tumor from inside. You preserve the stalk, you preserve the basilar artery, the liquid membrane here, and the terminal basilar, superior cerebellar, posterior cerebellar artery, with the preservation of olfactory tracts. It's a good approach. One case of mine, 5 months old patient from Jordan with what I call the Hiroshima and Nagasaki. It looks like the bomb of Hiroshima, really. It was frightening. And we went for radical excision. This 5-year-old male patient with this tumor extending from foramen of Monro to the foramen magnum. And you can see part of the tumor was calcified. We could actually remove it completely. This is before and this is after. This patient from Yemen, 13-year-old male patient with this tumor, a large one, total excision. This boy from Iraq, back in '98, with this extensive tumor, extending again from foramen Monro down to the foramen magnum, retrocellular extension, total excision. He's an adult and he's been practicing ice skating here in, not here, back in Iraq, in Kurdistan. This lady from Libya with this extensive tumor almost blind, and we could radically take a tumor out. Notice, no shunts, no radiation. This man from Libya with this tumor, before and after. This 15-year-old male patient from Sudan with this preoperative extensive tumor, and the tumor being removed with the preservation, and he's growing very fast. I mean, the patient is doing very well. This Jordanian patient residing in Qatar, 24-year-old male with this extensive tumor going everywhere. This really gave me heartache when I saw it. How can I manage this? That's by perseverance and by following the dictum that I want to go for radical excision. Nothing is going to stop me unless I feel that I'm going to damage the patient. But I will do everything I can. I go in with the state of mind, I'm going to take this tumor out completely. And to get this result immediate post-op the following morning, to follow him up like this, is doing very well indeed. This lady came to us from outside Jordan, from the Gulf area, 73-year-old lady. People attempted that biopsy. It ended with a carotid aneurysm. Again, she was referred to us for radiation. We refused. We went and took completely the tumor after we neutralized the aneurysm with coiling. I call this patient the story of my life. 3-year-old, 2-year-old patient with this extensive tumor back in the year 2000, immediate post-op, follow him up and looking at him 20 years later, a young man in the university. It gives me the pleasure of my life. Here he is. Some people speak about recurrence of the cases. It's actually residual. And the radiologists in this part of the world, in Jordan and the Arab world, in Asia and in the Middle East, people do not differentiate between recurrence and residual. We have to be, exact. This is a residual tumor. People just went in and took small piece. So don't speak about residual. This is, don't speak about recurrence. This is residual tumor. This patient with this extensive tumor again, center elsewhere, they have put shunt, they have done nothing except for biopsy. And this is the seedling across the pathways. So what we did is to totally excise it completely. And this is long-term follow-up. The boy is growing well and is doing well. 25-year-old male patient from the Gulf area with this large tumor. And what did they do? Shunt. This really breaks my heart when I see this. I think the neurosurgeon who has done this should be put in jail or should be stopped from practice. So this is the tumor. Craniotomy and the shunt, they have done nothing. They have just punctured the cyst. And the neurosurgeon went out proudly and told the family, we have reduced the pressure, we have decompressed the cyst. Actually, he has done nothing. He's done injustice to the patient by just puncturing the cyst and putting a shunt. Came to us and we went in and took it out. So this is redo, but still, there's no place for radiation. You go for surgery. This 25-year-old male patient with this extensive tumor, again, somebody had attempted, but without any success. This is from North Africa. He came to us with the adhesions of the previous surgery, but eventually we managed. Nerve left, nerve right, chiasm tract, can see the carotid and divisions, can see the basilar artery, total radical excision of this residual tumor who had previous surgery. In my hands, of course, the cases I showed you were the cases that were done somewhere else and sat elsewhere and came to me. But there are cases that I had recurrent in my hands. So let's go through that quickly. This 3-year-old female patient from Palestine came with this tumor, 2005. I totally excised. Look, total excision. And she was doing well. She went back to Palestine, asked the follow-up, and then 2 years later, she came up with this most extensive recurrence. What is the treatment? Another surgery, another radical excision. And this is following her up, being a young, beautiful young lady with no recurrence, and no radiotherapy, and no shunts. A 61-year-old male patient in Jordan with this tumor. I've removed it completely. 2 years, 3 years later, coming with recurrence. What's the management? Surgery, not radiosurgery, not radiation. So we went in and totally excised it completely, and he's doing well. 4-year-old male patient from Sudan with this extensive tumor. Again, what did they do? They put a shunt. But I cannot hammer this point enough. This should not be seen in the current contemporary neurosurgery. It's wrong. So he came to us and we did the radical excision. That's immediate post-op. And people would say, oh, what is the hypothalamus? It's gone. It's not. It's been pushed aside. So here you say, where is the hypothalamus? I will tell you, it's on the sides. And the patient was well after this tumor. He came back some years later with this recurrence. And what did we do? No radiation, going again for excision, and he is doing well. Beautiful child. So all in all, in my series, I have done total radical excision in 84 out of 102. So some of cases I did not do. Why? Because it was impossible to do radical excision. The tumor calcification will go into the wall of the carotid or insinuating itself inside the chiasm and so on. So you accept defeat. I would say accept defeat by not doing total resection. Of the total resection, I had recurrence in 11. I had mortality in 1. And the subtotal resection, I had recurrence in 16, and I had mortality in 1. So I will share with you some of one of the cases of the morbidity, some of the cases of morbidity and the mortality. The morbidity in my case is subdural hygroma, hydrocephalus, CSF leak, meningitis, like in any other series. And of course, DI, endocrinological deficits increased, worsening of vision very few, psychological symptoms in 9%, seizures in 7.3%. And as I said, I had 2 mortalities. This is one of them. It was done at St. Elsewhere at another hospital. This is the craniotomy. They have done nothing except to puncture the cyst and lie to the family that they have decompressed the optic chiasm. He came with this lesion. Again, he was referred for radiation by gamma in Jordan. I refused to, and I gave the current treatment of surgery, but unfortunately, he deteriorated and died on the 7th postoperative day We could not tell the cause of that. But remember, he had surgery somewhere else. And now to the last point in this discussion about the obesity in craniopharyngioma that people are afraid of. As I said, if you have seen the patient obese before surgery, this is definite hypothalamic involvement, and this patient would not lose the weight afterwards. But if obesity develops post-operatively, then usually there is a good subsequent weight loss and recovery. So this is obesity. This is not from my cases. This is from textbooks. This is the patient before and after. So obesity is a problem to be observed. In my series, I have seen this, especially in children. So you can see this patient with the obesity, and then it disappears in about 2-3 years' time. Look at this. Or this one, obesity, and then disappears. So all these patients, young patients, develop some obesity, but they disappeared completely afterwards. Why? Because we preserve the hypothalamic function. In adults, I did not see this. I did not see any obesity. We preserved the hypothalamus, but they did not have any obesity whatsoever. I will show you some videos and we'll be finished. I'll start with the first video. It will not take much. We'll just show the pertinent features in the surgery and trying to hammer the point that radical excision is possible. You just need to be knowledgeable of the anatomy, of the pathology, of the embryology, and of the characters of this. So this is one patient, olfactory tract preservation, interhemispheric. We're going through the lamina terminalis, and you can find a good plane of image. So here you are separating it from the junction of the nerve with the chiasm. So don't tell me that leaving this is doing justice for the patient. This is the liquid membrane, this is midbrain, preservation of the stalk, this is the basilar artery and its ramification or branches. I'm sorry if my voice is just disappearing. I'm fasting. I've been fasting since sunrise, and we are waiting for the fasting to be broken in about 1 hour time. So my voice is disappearing. This is another case where I go through the lamina terminalis, and here's the olfactory tract. And as I said, evacuating this fluid is not the treatment. Nonsense. Don't lie to your residents and to the families saying that we have done what should be done, and we could not remove it because it was adherent to the optic apparatus. Of course it is adherent. It must be adherent, but it is your job to find a good plane of cleavage and remove it completely. Again, lamina terminalis approach is a good approach, especially for those cases going into the third ventricle. Don't hesitate using the ultrasonic aspirator in these cases. And if the tumor is involving the stalk is cut and removed with the tumor, I would not leave a tumor on the stalk, even if it is a child. Tumor on the stalk means it has to be removed. So here you are having punctured the cyst and removed the tumor, the fluid, you're still having the tumor. This is a good plane of cleavage. Don't tell me there is no plane of cleavage. This is old teaching, old in neurosurgery. It is no more applicable. Don't lie to your patients. Don't lie to your residents. So this is the crus, both sides, front of the midbrain. So this is the taking the tumor completely out. Some people say, are you pulling? Don't you think that there may be some adhesion to the basilar? Most of the time, there is no adhesion to the basilar complex. And here I'm looking and I'm seeing the aqueduct of Selby's. Another case where you can see the lamina terminalis here. Again, this is the fluid we have removed. We are putting patches to prevent any chemical meningitis. Well, this is not the treatment. We have to remove the tumor. And then you have seen that I'm cutting here the stalk because the stalk is tumorous. So the stalk has been cut here, and I'm taking the tumor from the lamina terminalis. So you can see a good view, the nerve, the chiasm, and the posterior fossa structures. This is the last video, just take 2 minutes, and we'll be open for your questions. This is interhemispheric approach, right side, left side, and dissecting the interhemispheric arachnoid, and then going in. You can see the tumor here in the lamina terminalis. Again, taking this out is not the treatment. This is nothing. You have done nothing. You have done no justice to the patient by just taking this tumor out. So here we are taking it, and you can see the ACOM here. There's the Stoke. So you work pre-chiasm, post-chiasm, and then you deliver the whole tumor out. I'm not hesitant to use the ultrasonic aspirator if the tumor is really hard in consistency. Same picture. So it's not one case or two cases. This is a school of thought of radical excision of the tumor, taking every step you can, taking every effort you can to remove the tumor completely. If this is your child, giving him to a neurosurgeon, you would wish that this neurosurgeon would not put a shunt or refer for radiotherapy. The last picture that I want to show you about this case, which has been done recently, just to show you that taking the content of the tumor out is not the goal. We are now sucking the content of the sac. It's not enough. I have done no justice for this patient. I have to go and remove the tumor completely. Here you work right, left, center, you go everywhere. You are taking the tumor completely out. Here I'm going between the carotid and between the optic and the carotid on the left side. Still the tumor is here, tumor is here. So this is the beauty of this approach. You can see the carotid here, see the tumor. Right side, tumor is still here, attached here. So I want to remove every ion of the tumor. Imagine if I lift all this tissue inside. So again, it's not enough to puncture the cyst. It is not at all recommended to use a Meyer reservoir. It's not recommended at all to give radiotherapy or radiosurgery. Surgery is the mainstay. If you are not good enough, don't do it. Don't do what suits you to gain money to send patients for radiotherapy or to put a Meyer reservoir. The good thing for the patient is surgery. Refer him to a good neurosurgeon, whether in your country or somewhere else. Don't refer him to me. I'm not asking you to refer him to me. For him, I'm sure there is in every country good neurosurgeons who can do the surgery. And there are so many bad neurosurgeons who will do Meyer reservoir, shunts, and radiosurgery. So this is the stroke, and there is some tumor left in it. I will dissect it of it. I will try to remove every ion of the tumor completely out. So these are the principles of the surgery which I alluded to. And now you can see stroke, which is well preserved, and everything is there. Okay, with this I finish, and I thank you.
Okay, thank you very much, Dr. Sabea. Let me get you off the screen. Can you stop screen sharing there? I can take you off here. Let me just take you off here so we can see ourselves here. Okay, great. We have a good amount of panelists. So for the panelists, please, let's interact. Let's use this tool to interact with Dr. Sabea. So the floor is open. Please share your thoughts, questions, comments?
Hello, Dr. Sabia. It's
Hello.
me, Dr. Adnan from Pakistan.
Nice
We
to
are
meet you.
regular student. Sir, thanks a lot for a wonderful talk once again. This week we had two in Monday and Wednesday, and hope we'll have many more in the next week and coming month. Sir, I have heard your this talk and the previous you spoke your view about in PSN webinars. I support your stance about the how should be the training for the residents and for the surgeons. Sir, regarding this case of craniopharyngioma, you are telling, sorry, I came a bit late, so I couldn't hear whole talk, but the last part I heard. I will ask your opinion, how we should decide for the choice of approach. You prefer interhemispheric approach or that other one is for frontotemporal or any other approach?
Sure.
What is the choice of approach?
Sure.
Thanks.
The extent of the lesion, the size of the lesion, where the lesion is extending retrochiasmatic or going to the foramen of Monroe, or go to the foramen magnum, will decide the approach. And many times you may need two approaches, not one. I'll give you, for example, Professor Maurice Schux from France would use the transcortical, transventricular. You go into the foramen of Monroe and then goes into the tumor. He likes this approach. I don't subscribe to this. I like to see the origin of the tumor is from below. It's not from above. So I want to attack the origin of the tumor. So that's why I go from below. And from below, for me, the tumor is going into the third ventricle, lamina terminalis is very good. If the tumor is just below the chiasm, then I will go terional. So it is not your choice. It is what you see in the image, what you see in the extent and the size of the tumor. But I warn you, you have to have good experience on all approaches. Otherwise, you will be prisoner of one approach, and then we'll treat all the cases with one single approach. And this is wrong.
Okay, sir. Thanks a lot, sir. Thanks a lot.
Okay, thank you. More questions, comments from the panelists?
Hi, Dr.
Hello, John. Can I talk?
Yes, go ahead. Go ahead, Sam.
Yeah, it's me, for me.
Yes.
Yes, Sammy, yes, it's for you.
Okay, thank you. I'm really enjoying always I'm enjoying you, Dr. Sbeh. Just to state and agree with you 100% that no rule at all for radiotherapy upfront as benign or malignant tumor. So thank you for the lecture. I'm really happy because the survival rate that I'm having with the brain tumors is really due to the excellent job that you are doing and the high percentage of the radical excision that you are doing.
Thank you, Sammy. And again, coming from you as a radiation oncologist, it means a lot to me because you are an honest radiation oncologist. You would not, and I know of cases of some people referring to you, cases, giant tumors where they took biopsy, and you refuse to give radiotherapy because you believe in this. Radiotherapy is an adjuvant treatment. It is not an upfront treatment, whether it is for a glioblastoma multiforme or for craniopharyngioma or for any lesion as such.
And only adjuvant for the good excision of the tumor,
Absolutely.
not only for
Absolutely.
the biopsy.
Thank you very much indeed, Sam.
Thank you. Thank you.
Very good. Thank you. Okay, more questions, comments for Dr. Sabia?
Yes. Assalamu alaikum, Dr. Ibrahim.
Oh, welcome. Welcome.
Nice to see them.
Dr. Ibrahim, I have two questions actually.
Sure.
I've done plenty of cases actually, which was on multiple approaches, like Professor Lapra, if you remember, was teaching us. If you have a lesion which is extending into third ventricle and going down into the prepontine cisterna at the same time, do you have the experience of doing multiple approaches at the same time? Meaning going intercallosal or transfrontal, and then at the same time going terional or interchiasmatic through the lamina terminalis. What's your opinion about that?
Right.
Let's take a question to that.
Okay, so I'll answer this question. Under my belt, I have 102 cases of craniopharyngioma. I did not have the need to do 2 stages. So even for those cases where they are extending into the posterior fossa, into the foramen magnum, I could reach them through the lamina terminalis approach. So I believe in this approach and for these large cases extending everywhere. So I did not use it. I know people can do 2 stages or 3 stages, but it is good for the patient to use 1 stage. What's your next question?
Well, I did it in 2 stages, but Professor Lapra was doing it in the same stage, same surgery, doing a transcallosal and then a transterional, and at the same time in the lamina terminalis.
Sure.
So, I mean,
yes, of course.
How is your experience regarding the difficulties and the length of the surgery? Because, well, I didn't have the same number like Professor Lapra or like you, but I think it's a little bit difficult to do the same thing.
Well, as I said, once you do something and you do it in many times and you learn how to do it, then you are master of it. And when I started doing the interhemispheric, the dissection of the olfactory tract used to take a long time. But my intention was to preserve these. By experience, it just takes about 20 minutes now. So I don't think it adds length of time, but it gives you the power of really seeing all the lesion. You don't have any blind spots whatsoever. Interhemispheric, lamina terminalis, you are in the center, you can go the left, you see opticocarotid, the right, opticocarotid. You can go precast, you can go through the lamina terminalis into the posterior fossa. So it is good, versatile approach to give you the ability to take the tumor out completely and to preserve the neurovascular structures.
Are you obliged to remove the part of the falx? I mean, do you pull out the falx or do you detach the falx from the beginning? Or not?
Yes, of course. What I do is this: is to cut the superior sagittal sinus and the most anterior part, very, where it goes into the crestical eye, and then cutting the forks, and then go interhemispheric. So this way, I'm not doing any retraction. I'm just going into the interhemispheric space.
You didn't have any olfactory nerve affection in such cases?
No, I preserve them. Now, when I preserve the anatomy, doesn't mean I preserve the function. But I'm not like those surgeons who would, the first step would take the bipolar and just cut the olfactory. Olfaction is good thing for us. I need to smell the good smell of food or drink or whatever. So it's important for me as a human being. So I'd like to preserve the anatomical integrity of the nerve, but that doesn't mean that I'm preserving the ophthalmic function. In my series, 70% of them preserve their olfaction.
Okay. Second question. I had assisted Professor Lapra for such cases, which I didn't do here, in inserting catheter with an Omeya reservoir to give temporarily some doses of pleomycin inside the cyst. And we did some paper behind that. Well, in one of the patients, it was catastrophic because it had some sort of chemonecrosis due to the leakage of the CSF due to the pleomycin. But what's your experience and opinion about this? Thank you.
I do not prescribe whatsoever to Omeya reservoir use as an upfront or as an adjuvant at all. Unfortunately, I did not need to go to
only temporary. I'm saying just in the sake of reducing the size of the tumor.
Remember the recommendation from Mayo Clinic: do not use it if you are planning to do surgery. So it is not good. I don't prescribe it. I don't subscribe to this. I don't believe it adds anything. Just additional maneuver, additional waiting, additional complications for no good reason.
Thank you.
Thank you.
Okay, more questions, comments from the panelists? No, okay. Okay, Dr. Sabea, thank you very much. And next Monday, correct?
Monday at 5 o'clock, we'll be talking about the aneurysmal bone cysts of the skull base.
Okay, very good. Thank you very much, and we'll see you then. Thanks to all the panelists. Good day.
Good day to you.
Okay, very good. Okay, thanks for restarting, Dr. Sabea. And thank you, Dr. Zayden, and thank you, Sam. for your comments. And thank you, Adnan. Once again, then you're getting a pretty good record here. Hey, Joanna. Joanna?
Hi. Hi.
I hope you don't think you're going to get credit for attending this.
No.
Of course
I
not.
thought-
You can't just slip. You can't just slip in and say, "Give me credit for that attending the conference."
I totally missed it. So sorry. My
Yeah,
bad.
you saw the ending credits. That's what you
Yes.
saw.
Yeah, it must have been really excellent. I'm terribly sorry.
Well, that's okay. Yeah, he's very complete. I mean, I don't know anything about radiotherapy and craniopharyngioma, but he doesn't look upon kindly to using radiotherapy before surgery.
Yeah, I have to check it from video record now.
Yeah. Oh, I guess. Have you done any craniopharyngiomas? Is that a pretty common tumor? Or?
No, I haven't.
No, it's
No.
pretty rare.
Yeah, it is. Yeah.
Oh, okay. Okay, very good. Okay, Joanna, we'll see. We have another one in 45 minutes. Let me show you. Oh, let me show you and the rest of the panelists.
Okay.
What this is like a commercial. Okay. It's a neurosurgeon from Cleveland Clinic in Florida. Okay, let me share the screen here. Well, are you there, Adnan?
Yes, I am there. Yes, I
Yeah,
am
I'm
there.
gonna show you this. I'm showing Joanna the next in 45 minutes. This neurosurgeon is from Jacksonville, Cleveland Clinic, Cleveland Clinic in Florida. He's going to talk about limbic structures and surgical pathology. You know, Joanna, it just takes someone to organize all this stuff. There's a lot of stuff out there. It's just
I know
organizing
that.
it. It's just
I know that.
organizing it.
Yeah.
Yeah, a lot of people are doing good stuff, but I think most of it goes unnoticed because there's just such a deluge of it. So anyways, yeah, maybe we'll see you guys there. We'll be here at noon. This won't be interactive like this one. It'll be strictly televising. If you want to interact, you can actually go into the WebEx. You see the address here?
Mm,
If you want to go into the conference itself, you just click on this link.
okay.
And
Can you
go in.
also send us the link straight or?
Yeah, it's on the
Possible?
page.
Oh,
Yeah, I'll send you this link anyways.
thank you so much.
Yeah, I do
Please,
accept tips,
John.
Joanna, too.
Please
Yeah.
share this to Neurosurgical TV WhatsApp group. I think you have not shared this link.
Okay, I'm gonna put it in the chat box here, okay?
Okay. And there is another one from Saudi Arabia as well today.
There's another couple good ones, right?
Yeah. Then
Yeah, if you ever see any good ones, Adnan, just let me know, okay?
Yeah.
Because sometimes the people, okay,
Okay,
there's
I
the
will
link,
communicate.
there's the link, Joanna, to get into the panel.
Okay. Yeah.
You gotta add
Yeah,
in if you want to get right into the panel there. It's a
Yeah, I
WebEx.
will communicate with you
Yeah.
about there's a few one in a couple of hours. I will share with you through WhatsApp.
Yeah,
But
they're
I think
different
that-
though. Some let you interact and some like you can't. You just have to send your questions. So I have
Yeah.
no idea what this one's going to be like. But from my perspective, I'm just televising it onto Neurosurgical TV to save steps, to make it easier. So, okay,
Thank you.
okay, Joanna, we'll see you later.
Yes.
See you, Adnan.
Okay. See you.
Thanks a
Bye,
lot.
John.
Bye-bye.
Bye, everybody.
See you. Bye.